Hello everyone, welcome back to Capsa. So this is the final video of vesicular monoamine transporter playlist. So far we have covered the structure, types and distribution of VMAT, its mechanism of action, including the proton coupled antiporter system. Today we will discuss the pharmacological and clinical relevance of VMAT, focusing on drugs that inhibit VMAT and their mechanisms, diseases and disorders associated with VMAT dysfunction, the clinical use of VMAT inhibitors in neuropsychiatric conditions, and potential directions in therapeutic targeting of VMAT. So let's begin. Let's start with the main pharmacological inhibitors of VMAT. The classic one is Reserpine. It irreversibly binds to both VMAT1 and 2, blocking the entry of monoamines into the vesicles. As a result, norepinephrine, dopamine, and serotonin get depleted in both brain and periphery. It was historically used as an antihypertensive, but is now rarely used due to significant side effects, including depression. A more selective option is tetrabenazine or TBZ. It's a reversible inhibitor of VMAT2, meaning it mainly affects monoamine storage in central nervous system, especially dopamine. Then we have valbenazine and deutetrabenazine. Newer derivatives of tetrabenazine, they have improved pharmacokinetics, meaning they last longer in the body and have fewer psychiatric side effects. Both are now FDA approved for the treatment of tardive dyskinesia, a disorder characterized by involuntary movements. So, what happens when we block VMAT? In the central nervous system, VMAT inhibition reduces dopamine levels, which can lead to symptoms like bradykinesia, tremor, and Parkinsonism. This is a key concern with drugs like TBZ or tetrabenazine. Lower serotonin can contribute to mood disturbances, including irritability and depression, while norepinephrine reduction may lead to fatigue and sedation. In the peripheral nervous system, especially with non-selective inhibitors like Reserpine, inhibition of VMAT1 reduces catecholamines in the adrenal medulla, causing hypotension, bradycardia, and digestive symptoms. That's why newer drugs target VMAT2 selectively and minimizing these peripheral side effects. Now let's look at the clinical use of VMAT inhibitors. Tetrabenazine is used to manage chorea in Huntington's disease, a condition marked by excessive uncontrolled movements due to dopaminergic overactivity. If you want to know more about a very interesting disease, Huntington's disease, check the link in the description. It's also used off label in the Tourette syndromes, though with caution due to its psychiatric side effects. Check the link in the description to know more about the Tourette syndrome. Valbenazine and deutetrabenazine are currently the preferred drugs for tardive dyskinesia, a condition caused by long-term dopamine receptor blockade, commonly due to antipsychotics. So these agents reduce involuntary movements by lowering excessive synaptic dopamine without drastically affecting mood and or autonomic function. However, all VMAT inhibitors require monitoring for side effects, particularly depression, suicidal thoughts, and Parkinsonian symptoms. Also, in susceptible patients, there is a risk of QT prolongation, which may predispose to cardiac arrhythmias. Beyond drug targeting, VMAT dysfunction is involved in several neuropsychiatric diseases. In depression, reduced VMAT activity may contribute to low serotonin and norepinephrine availability. In Parkinson's disease, the dopaminergic neuron loss is often accompanied by a decrease in VMAT2 expression, further limiting the dopamine storage. Schizophrenia has been associated with regional VMAT2 overactivity in some such studies, while ADHD may involve altered monoamine storage and turnover, possibly implicating VMAT function. Interestingly, VMAT2 is also a biomarker using PET or positron emission tomography tracers like dihydrotetrabenazine. Clinicians can visualize VMAT2 distribution in the in the brain, and aiding in the diagnosis of Parkinson's disease and related disorders. To summarize, VMAT inhibitors are valuable in treating hyperkinetic disorders by reducing synaptic dopamine. Reserpine is outdated due to irreversible action and side effects. Tetrabenazine and its derivative offer a safer, reversible, and more CNS selective options. VMAT dysfunction is not just pharmacological, it's pathological, with which links to the depression, Parkinson's, and many more. And finally, VMAT2 is even being used in neuroimaging as a diagnostic marker for dopaminergic neuron loss. So you can go through these takeaways. Thank you for staying with CAPSA through this VMAT playlist. If you found these lectures valuable and makes you to subscribe to CAPSA and tap the bell icon so you don't miss our upcoming series. See you in the next lecture.